All right. So the next important question, like every time they ask this question, they will give you a same clinical features which are asked hundreds or thousands of the times. Like postmenopausal female presents with the history of pain and swelling over the wrist after falling down the stairs. Plain radiograph is given below. What is the diagnosis? You know, as I told you already, that the most important hint in the clinical question related to Colles fracture is that every time they are going to ask a question related to Colles fracture, then this is the hint which will be provided. Like elderly female, all right, elderly female and the wrist pain or the wrist injury to the wrist. When you see both of these findings which are provided to you in the question, then go with the answer of the Colles fracture straight away. Like in this question, it would be difficult for you to identify the Colles fracture on the X-ray. But when you have read the question carefully, just based on these two hints, you can go with the answer straight away with the Colles fracture. Now, what are the 2 points which are provided to you in the question? One, elderly female, postmenopausal women, and sustained injury to her wrist with a visible deformity. So, answer for this question is Colles fracture. Now, all you have to know about a Colles fracture for its identification on the X-ray is that on the X-ray, how will it appear? Like there will be a fracture of the distal end of the radius. Now, this distal end of the radius fracture will appear at a cortico-cancellous junction. This is the cancellous region, cortical region. So, at the cortico-cancellous junction, and it will also result in the dorsal displacement. Now, when you look at the lateral view, if this is the fracture, this is the dorsal part, this is the ventral part, dorsal part, ventral part. So, the distal end is going to be tilted, it will be shifted or either displaced dorsally, which will give it an appearance of a dinner fork. So, that is why it is also called by the name of dinner fork deformity. So, on the X-ray, what you can very clearly see is that there is a fracture at the cortico-cancellous junction in the distal end of the radius. Now, in the lateral view, the distal end of the radius is dorsally displaced. It is tilted dorsally. And this dorsal displacement or this dorsal tilting is responsible for identifying or making this fracture identified as a Colles fracture. So, answer for this question is straight away Colles fracture. Now, apart from this other, if you look at or if you consider the other options, like a Smith fracture is also the fracture of distal end of the radius, which is also extra-articular. That means cortico-cancellous junction involvement. But the only thing which is different in reverse in this Colles and Smith fracture is that in a Smith fracture, there will be a ventral displacement, while in Colles fracture, there was a dorsal displacement. As far as Galeazzi and Monteggia fracture are concerned, I already told you how so many times, hundreds of the times we have already discussed. The fracture of the distal radius with distal radioulnar joint dislocation is Galeazzi fracture. The fracture of the proximal ulna with proximal radioulnar joint subluxation or dislocation is Monteggia fracture. Alright. So, answer for this question straight away is a Colles fracture. Every time you get a question related to Colles, what are the things that you should be knowing about is the definition. Second is dinner fork deformity. Third are the complications related to Colles fracture. And the fourth one is the management. Because in the management of the Colles fracture, it is done by closed reduction. That means by traction manipulation, you are going to reduce the fracture, and immobilization in Colles cast. Colles cast, which is also known by the name of handshaking cast. And so many factors we have discussed about this Colles cast also. Like in Colles cast, the wrist is immobilized in flexion, ulnar deviation and pronation. It is a below elbow cast. What are the reasons for that? What are the steps in the management? That means after the traction, what you have to do? How will you disimpinge the fragment? How will you reduce the fragment? So all these things we have discussed in huge details in the lectures of the orthopedics related to Colles fracture. Colles fracture is a commonly asked question. Okay. So, elderly female, wrist injury, Colles fracture, straight away. Next question. A 60-year-old, now here what they have provided, a 60-year-old male presented with the limping gait and left hip pain. So, the patient is presenting with the limp and he is having a pain also. A 60-year age is also provided. Plain radiograph of the hip shows the following findings. So, first of all, in an adult, if you look at the differential diagnosis of limp and pain in the hip joint, so what are the differentials? The differentials for this particular condition are: 1, the tuberculosis; second, the osteonecrosis, that means the osteonecrosis, head of the femur; and the third one is osteoarthritis. Now, this osteoarthritis, although primary osteoarthritis in India of the hip joint is less common, but it is very, very commonly observed finding in Western countries. That is point number one. Yes, secondary osteoarthritis happens with any condition of the hip joint. Might happen as a secondary osteoarthritis. All right. So these are the three common differentials that you have to consider in a patient who presents to you with the pain and limping. And here in this particular question, they are asking that on the basis of the x-rays only, how you are going to come out with the final diagnosis. So what you have to look at the joint, that means this is the acetabulum and this is the head of the femur. So what are the findings that you can very clearly observe in this particular question? The first one is that the joint space is preserved. And you see, the moment the joint space is found to be preserved, the joint space is found to be normal, where the joint space is not reduced, tuberculosis is excluded out. The moment you see the joint space is preserved, TB is excluded out. So it is probably not tuberculosis. Now, what are the other findings in tuberculosis of the hip joint? That also will suggest that probably this is not the X-ray of the tuberculosis of the hip. The second one is there will be periarticular osteopenia. That means decreased density of the bone around the joint. Now here you can very clearly see that there is no such thing which is happening. The density of the bone is not at all affected as far as decrease in the density is concerned. So it is absolutely normal. So probably this is not the X-ray of the tuberculosis of the hip joint. Now, when the joint space is preserved, it also gives you a feel that probably this is not the X-ray of the secondary osteoarthritis too. Because in osteoarthritis, there will be a reduction in the joint space. So the moment joint space is found to be preserved, osteoarthritis as well as tuberculosis are almost ruled out. So possibly you are left with osteonecrosis head of the femur. Now this osteonecrosis head of the femur, how you are going to make the final diagnosis? That means what are the findings which are suggestive of osteonecrosis are presented to you in the X-rays. So what are those findings? If you look at this head of the femur, now this head of the femur is found to be sclerosed. There is increased density in the head of the femur. And this is the early X-ray finding for osteonecrosis head of the femur. So there will be a sclerosis head of the femur. Although this is the earlier identification of the X-ray, you cannot say that on the basis of the X-rays only I have made the diagnosis. Until and unless there is a flattening of the head of the femur, there is crescent sign positivity, there is lateral migration or lateral subluxation of the head of the femur, there is proximal migration of the head of the femur, alright, all those things are the cumulative findings. That means with the increased severity of the disease, all those findings are going to help you out in making the correct diagnosis. But here what is happening, there is increasing density of the head of the femur which can be very clearly observed, and that increase in the density of the head of the femur along with the loss of clear-cut sphericity in the head of the femur. As you can see, the head of the femur is not clear-cut spherical. There are irregularities in the head of the femur which are clearly evident in this particular question. If you look at the surface, there are irregularities in the head of the femur which are evident. So possibly we are looking at the X-rays of osteonecrosis head of the femur. So what are the catch points out of this question? That means what are the takeaway points by this X-ray which is provided to you? Point number one is you look at the joint space. If the joint space is found to be reduced, probably tuberculosis or osteoarthritis. If joint space is preserved, probably not tuberculosis or osteoarthritis. Then what else then? It could be osteonecrosis head of the femur. How will you identify that osteonecrosis head of the femur? There will be increase in the density of the head of the femur. Point number one, that is sclerosis. Point number two, there will be a loss of sphericity of the head of the femur. That means there will be flattening, gradual progressive flattening of the head of the femur. Point number three, there will be crescent sign positivity. That means there will be a appearance of a subchondral fractures, which is very less likely seen on the normal X-rays or plain radiographs. Point number four, there is going to be a lateral subluxation or lateral migration of the head of the femur. There will be proximal migration of the head of the femur, but the joint space is reduced until and unless joint space is not reduced, in osteonecrosis head of the femur until and unless secondary osteoarthritic changes starts. So it is considered to be the last finding in osteonecrosis head of the femur. That is avascular necrosis head of the femur. So that is the possible answer for this particular question. What is the most likely diagnosis? The most likely diagnosis based on these observations on the X-rays itself It is osteonecrosis or avascular necrosis head of the femur. We already talked about this in huge detail. It's practically also very important. The examination of the entire hip is dependent on these observations of the osteonecrosis head of the femur. In your coming future related in your future examinations, it will play a major role. Majority of your long cases, in the next examination, NEXT next examination, majority of the long cases are going to be those of osteonecrosis head of the femur, avascular necrosis head of the femur. Mark my words. All right. So it is an important topic. It is going to be an important topic in coming of your examinations. Next the next question is 14-year-old. Now again, a question which is related to tumor, and it is extremely important to have or to mention the age of the patient. 14, that means less than 20. That means a skeletally immature individual. Presents with the pain around the knee joint. His radiograph image is given below. Which among the following is the management for this particular condition? So they are just asking about that what is the diagnosis based on the x-rays and what is the management for this particular condition. So you have to make the diagnosis first, then the management. Now if you look at the x-ray of the knee joint AP view, here is the distal femur. So distal femur is absolutely normal. There is no abnormality. But here in the proximal aspect of the tibia on the metaphyseal location, there are cystic changes. All right. So these lesions are identified as cystic lesions in the metaphysis of the proximal aspect of the tibia. So if you look at further, if you characterize these cystic changes, then these are loculated, these are septated. All right, multiple septations are present. So there are loculations, there are septations. All right, then it is an outpouching kind of a lesion. That means there is an associated thinning of the cortex. The cortical thinning is also present. Cortical thinning is also, it is associated with the cortical thinning. All right, so when you find this kind of a metaphyseal lesion, which is having septations, which are having loculations, which are associated with the cortical thinning, that means eccentric pattern of the growth, then answer for this question goes in the favor of aneurysmal bone cyst. And the management for aneurysmal bone cyst is extended curettage. You have to remove the normal margins also. And after that, based on the location, you have to fill it with the graft. You have to go for the ablation. You can go with the fixation if at all required. All right. But the answer for this particular question goes in the favor of extended curettage. That you have to go for extended curettage for this particular lesion. Wide excision goes in the favor of simple bone cyst. Radio frequency ablation, today radio frequency ablation is important because osteoid osteoma, anywhere in the body, osteoid osteoma is managed by radio frequent thermal ablation by percutaneous application, except for the lesions which are present in the cord, that means vertebral column, or in the hand bones. All right. So these are the two contraindications. Otherwise, radio frequency or radio frequent thermal ablation is used in the management of all these lesions. Wide excision, as I told you, it goes in the favor of simple bone cyst. Intralesional steroids, actually, today it is not going to favor any of the management of the or any of the conservative management for any of the tumor. Like denosumab today is recently been approved or FDA approved only drug which is used in the management of the GCT, but it has got its limitation. Surgical management remains the mainstay of the management of the bone tumor, particularly the benign tumor. And extended curettage is the management for aneurysmal bone cyst. So that is a particular answer for this particular question, identification. All right. So the next question is that match the following splint and the conditions where they are used. So simple, you just have to identify the splint and you have to identify the indication which are provided in the option. So first of all, going or on the basis of the image provided, let's identify the splint. The first splint, the number 1, the name of this splint is, this is Bunnell splint. Or this Bunnell splint is also known by the name of knuckle bender splint. All right. And this knuckle bender splint, first of all, how you have identified a knuckle bender splint, knuckles, the metacarpophalangeal joints, they are bent and then it is immobilized in a external splint. So that is knuckle bender splint. All of you know that knuckle bender splint is or the indication for the knuckle bender splint is the ulnar nerve injury, because ulnar nerve will result in the failure of lumbricals, as a result of which there will be a progressive claw. In order to prevent this claw hand deformity, it is immobilized in a knuckle bender splint. That is point number 1. Now, the next splint over here is the aeroplane splint. The second one over here is the aeroplane splint. And this aeroplane splint, why is it called by the name of aeroplane splint? Because the upper limb is immobilized in abduction. To some extent, it appears like a wing of the aeroplane. And the indication for this aeroplane splint is the brachial plexus injury. The brachial plexus injury. All right. So, non-specific kind of a brachial plexus injury is an indication for the use of this aeroplane splint. The third splint over here is, the third one is the cock-up splint. Now, it is not difficult to identify this cock-up splint. Why? How you have to identify a cock-up splint? If the wrist is immobilized in extension, simple. If the wrist is kept in extension, it is particularly a cock-up splint. And here the provision of the movement is also provided. So it is also known by the name of dynamic cock-up splint. So if there is no provision of movement, that means only it is statically immobilized in extension. It will be called as a static cock-up splint. If there is a provision of mobilization with a recoil movement of the upper limb bones into extension, then it will be called as dynamic cock-up splint. And dynamic cock-up splint, the indication, all of you are aware of the fact that it is the radial nerve injury, because in radial nerve injury, higher course radial nerve injury, there will be a wrist drop. In order to prevent this flexion deformity from getting permanent, it has to be immobilized into extension. So that is the reason why a wrist drop splint is used or a cock-up splint is used. And the fourth one over here, the fourth one is the cervical immobilizer, and because it is of the hard type, which is having a provision of a tracheostomy tube to be provided, used in the case of emergency cervical trauma, is a Philadelphia cervical collar. All right. So Philadelphia cervical collar, simple. There are 3 to 4 forms of a cervical collar. All you have to remember are the 2 forms. One is the Philadelphia and the other one is the hard or the soft cervical collar. Now, hard and soft cervical collar are used for degenerative condition of the cervical spine, while this Philadelphia collar, which is identified by the provision of the tracheostomy tube opening anteriorly, is used in case of cervical trauma, all right, in traumatic condition. The rest, only thing which is left is for you to match these down. So as you can see, the first one is the knuckle bender splint, and it goes in the favor of ulnar nerve injury. So 1D. So either this one or this one is the answer for this particular question. Now 2 is the aeroplane splint, which goes in the favor of a brachial plexus injury. So possibly the B is the answer for this particular question. Now you have to further confirm it. Like 3 is the wrist drop splint or cock-up splint, which goes in the favor of radial nerve injury. So here also it is correct till this point. And 4A, simple, the fourth one is the Philadelphia cervical collar, which goes in the favor of a cervical spine injury. All right. So hopefully you get the essence, or hopefully you have understood that how the questions are getting more and more easier, how the questions are practically being asked, and you have to be ready with the answers. There are just 20 to 25 topics in total. Around 8 to 9 or 9 to 11 are the number of the questions which are coming out of this topic, orthopedics, directly or indirectly. All the best for your future examinations. Hope you will get it cleared this time.